Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium. Thank you.
I would like to welcome all of you to the LE&RN online symposium, Removing the Mystery Around Bioimpedance, Moving Towards a New Standard of Care. I'm Sheila Ridner, and I will be presenting the symposium this morning from my office at Vanderbilt University in Nashville, Tennessee. The LE&RN Symposium series has been made possible by the generous support of multiple industry sponsors who share LE&RN's mission to improve the lives of people with lymphatic disease and lymphedema. This sponsored information is provided for you in consultation for use with your healthcare professional and is not meant to take the place of any interactions with your healthcare providers or any services you may need. Please contact your primary healthcare provider about any personal health concerns. Sources for the research that I will be discussing today include the Martha Rivers Ingram Professor of Nursing Endowed Chair at Vanderbilt University, multiple institutes from the National Institutes of Health, the American Cancer Society, Impedance, and MEDI. Today I'm going to talk about the importance of bioimpedance to the lymphatic community, tell you a little bit about what bioelectrical impedance actually is and how it works. We'll have a brief history of the evolution of bioimpedance, which, though perceived as being new, is actually grounded in many years of work and research. We're going to talk about the rapid progression of the science in the last decade. And I will also discuss my program of research and how that has informed my thoughts about the value of bioimpedance to the lymphatic community. And I'll close by talking about my thoughts regarding a need for perhaps a new standard of care. Why is bioimpedance important to the lymphatic community and to patients with lymphedema? About 140 million people worldwide suffer from lymphedema, and in developed countries, the most frequent cause is a consequence of cancer or its treatment. Early identification of the signs and symptoms of lymphedema should be integral to the management of all patients who are at risk for developing lymphedema, particularly those at known risk related to surgery, radiation, or other cancer treatments. When treated in the earliest stages, complications of lymphedema, like many other chronic conditions, may be minimized. There is a need clinically for a non-invasive physiological measure to assess lymphatic fluid status that can be done quickly and in both clinical and home environments. Over the past several years, researchers, clinicians, and patients alike have recognized this need, and that has led to an incredible amount of research in the past 10 years. What is bioelectrical impedance spectroscopy? Well, other than a big mouthful to say, BIS is an established technology that measures the extracellular fluid. And as you can see on the screen here, where these lines are, that is the space between cells to where the lymphatic fluid and extracellular fluid live. So impedance actually is able to measure this extracellular fluid. Bioimpedance passes a low-level electrical current through the body fluids and measures the body's impedance to the current. Bioimpedance is harmless, painless, and rapid. And the very low frequency, again, only goes through this extracellular space that you see. When patients with lymphedema begin to experience increased lymph stagnation and volume is beginning to increase in their affected body areas, you see a change of the normal ratios of distribution between extracellular fat, muscle, and tissues to a heavier extracellular fluid level that starts compressing or taking over space normally occupied by the muscles and the tissue. And impedance allows you early on to measure very slight increases in fluid in these extracellular places. The output from the current technology is called the LDEX unit. So if you were measured with bioimpedance right now, you would be told your LDEX reading is and be given a number. The historic normal range for LDEX scores have ranged from a -10 to a +10 because the LDEX values indicates the difference in the amount of fluid in an infected and uninfected area. However, some of these ranges are starting to be modified, and we will talk about that a little bit in the research section. So when did all of bioelectropedance research and ideas start? The idea for bioelectropedance spectroscopy, or BIS, arose in the 1700s when Dr. Galvani began to study electrical patterns in the tissues of the human body. In the 1940s, Cole began to model bioimpedance characteristics of different types of tissues, such as fat and muscle and extracellular fluid. And in the 60s, a group of scientists published work on the use of bioimpedance to determine body water volumes. In fact, I've read some of these other studies, and some were actually done in pregnant women to determine if they were becoming at risk for eclampsia. In the 90s, a big leap forward began for the lymphatic community when Dr. Cornish began proposing to use impedance as a way to measure lymphedema. And based upon Cornish's work in the 90s, in the early 2000s, the FDA in the United States recognized bioimpedance with LDEX values as a tool for aiding in the assessment of breast cancer-related lymphedema. And I began to use bioimpedance in my research in 2002 when this initial recognition was just forthcoming. In 2010 and beyond, we have now moved from the use of impedance only in breast cancer-related lymphedema to the use of impedance for other lymphedema locations in the body. And just to give you an idea of what has happened since the 90s, the lymphometer that you see here was the first prototype device that I used in my research, and this is the actual device. The XCA became the next generation, which was used in a home study by me. The U400 is the device that's currently being used in a large study that we have ongoing here at Vanderbilt. And the SOZO, which you see here on the side, is the latest incarnation of bioimpedance devices. And if you notice, one big difference in the SOZO and these other equipment pieces that you see is there are no electrodes required for the patients anymore. So I'm going to talk about my program of research, which has been a 15-year journey looking at bioimpedance in at-home and in-clinic settings. And my very first exposure to bioimpedance came in 2003 when I actually was completing my dissertation research. I attended a National Lymphedema Network conference in Chicago and met two ladies, Lucille Bridges and Nikki Conway, who were there demonstrating a new device that they had that they thought might revolutionize the measurement of arm volume in breast cancer survivors. This device was the prototype lymphometer that I just showed you a picture of. When I began doing this initial study, the underlying premises were that women with lymphedema after cancer treatment were distressed by their side effect. And based on my clinical observations as an advanced practice nurse, I thought these patients who had lymphedema had more symptoms than breast cancer survivors who did not have lymphedema. And there had been no research that actually compared the symptom profiles of patients with and without lymphedema. And you will see here in this photo an individual who participated in this very first study. So I did a study to compare the symptoms between those two groups and also to look at quality of life. And you might ask, why is this related to bioimpedance? Well, while I wanted to understand symptoms and quality of life, I also wanted to understand if the actual fluid volume or size of the limb had anything to do with the symptom profiles that I might find. So I enrolled two groups of individuals, 64 with and 64 without lymphedema, in a study. We collected self-report questionnaire information regarding symptoms and quality of life. I also asked them to write down anything we might have missed about their lymphedema experiences in a narrative form, and use the lymphometer to measure the fluid volume. Well, what did I find? First, I found there was a large group of symptoms that the breast cancer patients had when they experienced lymphedema that those breast cancer patients without lymphedema simply didn't experience. And this symptom cluster was published and has been out for now over 10 years in scientific literature. I also found, not surprisingly, that the lymphedema group had a poor quality of life as measured by 3 different quality of life tools. What I discovered in terms of bioimpedance results were that the greater the objective extracellular fluid in the individual's limb, the more severe their symptom profile was. So in other words, the higher the LDEX value, the more severe the symptoms. What else did I find in this study? Well, that the little lymphometer worked very well in a research setting. It was quick, took less than 5 minutes, and gave extremely valuable information for my study. But I also found that patients loved this device, and they asked repeatedly why they could not have it to use at home, and kept telling me, diabetics have the glucometer, why can't we have the lymphometer? And it was actually this patient feedback that led to the next study that I'm going to talk to you about, which was a study that we conducted here at Vanderbilt from 2011 to 2003, where we took bioelectrical impedance spectroscopy to a new level. We knew from our previous work that breast cancer survivors not only had lymphedema that required lifelong self-care, but that only half of them really did self-care as prescribed. And one of the reasons they did not do self-care is they had no perceived lack of positive results from it. In other words, they had no objective measure to tell them if self-care was helping keep their arm volume down or not. And this complaint about not having enough information to adequately manage their medical condition, coupled with the earlier findings that patients wanted to use this device, led us to apply for an R21 at NIH, which was funded, to develop a protocol for self-measurement and then enroll patients in a trial where we looked at how objective measurement impacted daily self-care activities and health and economic outcomes. In this study, we conducted an initial phase where we brought in both healthy women and women with lymphedema to develop the actual protocol. And the device you see here at the bottom of the screen is the device that we used in that study, which did require patients to apply electrodes. We developed this protocol, had people take it home and try it for 10 days, and decided that we were ready to start enrolling in our randomized clinical trial. And in our clinical trial, half the participants got the device to use at home for 3 months. The other half did not. And we collected the same information on patients who got the device as those who did not get the device. So what did we find? First, I would like to say that in this study, the patients were highly compliant with the 3 times a week impedance measurement they were asked to do at home. And we obtained monthly diaries and recordings of these readings while they were in the study and entered them into our database here at the university for subsequent analysis. The patients who were actually getting objective LDEX readings regarding the amount of fluid in their arms increased the amount of self-care they were doing during their time on the study. And while this control group, those who didn't get the device, actually did less self-care. And there was a little downward trend in the time both groups did self-care after we took away the device, because we followed these patients for a month afterwards to see if taking away the objective measure would have any influence, and it did. However, there was an increase from 2.5 days to 4 days a week of garment use in the intervention group who had the device to use at home, and that increased use of compression garments remained stable for that month after the monitoring stopped. So patients actually had a longer-term modification of compression garment usage after having received 3 months of objective feedback about how their limb volume performed on a weekly basis. Well, we had some unexpected outcomes from this study also. Patients wanted to purchase the device or keep it. And the only reason many patients even returned the device to the study was that we told them the truth, which was we had to have it to reassign it to yet another person who was going to be in the study. We had patients call Impedance, the manufacturer of the device, as they exited the study to see if they could purchase the device. And again, patient-consumer demand for self-monitoring continued. And that led to us publishing the results of the study and to me speaking with the company about the findings from the study. And we had discussions about perhaps there was a need to look at developing a device that could be used outside of clinical settings and in the home. The company eventually developed a prototype device that could be used not only for self-monitoring, but for quick assessment of lymphedema in clinical settings. And our research team here at Vanderbilt worked with the company on the human factors research in the design of this new device that did not involve use of electrodes. We enrolled patients with lymphedema, heart failure, and obesity, and they were of all sizes and genders. Every person who participated in evaluating the initial prototype device was ecstatic about the possibility of having bioimpedance as a self-management option in their home. And you might ask, why did we include heart failure and obesity? Well, while low-frequency bioimpedance is used to measure extracellular fluid, the lymph fluid, if you use higher frequencies, you can measure whole body water, like for heart failure patients, or you could measure fat and muscle composition changes in obese patients. So it has multiple uses outside of the lymphatic community. So as a result of our human factors research, the SOZO, which you see here, was released, and the patients told us that they thought this would usher in a new era of self-management, quote, similar to diabetes. So about 15 years after I first heard patients ask to be able to monitor like diabetics, a whole different set of patients, for the most part in this human factors study, told us the exact same thing. We want to be able to use this like diabetics do. You will notice in this picture that the patient that is with me using the SOZO was the patient in the very first study that I ever conducted. This picture I showed you. She has been a participant in many of our research studies, and is living proof that patients who stick with researchers and help us with our work can help make great differences in how chronic diseases such as lymphedema can be managed. So we've done a lot of work for self-monitoring and use in homes. And it's been very wonderful to work on helping people manage their lymphedema. But as a scientist and as a clinician, I'm also very much interested in preventing people from getting lymphedema if it's at all possible to do so. So now I'm going to switch from our research into more ambulatory and home-based use of impedance spectroscopy to one of our large in-clinic studies that is now being conducted. I'm the PI for this study, and we have multiple sites in the United States and in Australia. And the current study is funded by actually 3 different entities, Impedance, Medi, and the National Institutes of Health. The background for our current study, which we call the PREVENT study, is fairly straightforward. Over the past 8 to 10 years, increasing data has supported the idea that early intervention can improve outcomes for women with lymphedema following breast cancer treatment. And that there is an entity called subclinical lymphedema. And subclinical lymphedema is the equivalent for patients who are at risk for lymphedema to pre-diabetic conditions in patients who have diabetes. So this is where your extracellular fluid or lymph volume is changing in amount, but it's not yet to the point it is clinically diagnosable as a medical condition. And identification of subclinical use lymphedema is believed to be, again, the key to prevention. Bioimpedance is uniquely positioned to support early detection, unlike any other current method that we have available, because it can detect, as I told you at the beginning, that early sensitive changes in an extracellular fluid. Studies had shown also that if you put patients who were beginning to show symptoms of lymphedema in a compression sleeve and garment from 4 to 6 weeks, that you might be able to stop or slow the progression of the fluid. And the Stout-Gurgic study was the primary sentinel study in this area, and that engaged 4 weeks of treatment with compression garments and did have good outcomes in reducing progression to diagnostic thresholds for lymphedema. So we developed this very large international study to determine if this subclinical detection of extracellular fluid by bioelectrical impedance spectroscopy and subsequent early intervention with a compression garment protocol for 4 weeks of wearing compression garments and sleeves would reduce the progression of the swelling to full-blown lymphedema in comparison to identifying changes in whole arm volume using the current gold standard for measuring arms, which is a tape measure. This is a 2-group randomized clinical trial. Participants are screened prior to their breast cancer surgery. They are measured with both tape and LDEX, and 3 months after their surgery are randomized to either LDEX or tape measurement follow-up for 3 years post-surgical treatment. Again, the intervention is triggered when they hit certain key thresholds for tape and LDEX readings, and they again are enrolled in a garment intervention for 28 days. The data collection tools that we use include standard self-report demographics, medical and lymphedema history, symptoms, quality of life, and risk factors, such as airplane travel that they're engaging. We'll use a Gillick tape to measure with the tape measures, and we use the LDEX U400 by Impedance for the bioimpedance spectroscopy. So where are we with this very large study to date? We've enrolled about 1,200 patients worldwide. In fact, we're at 1,196 as of this morning, and we will stop enrollment when we have 4 more patients. We have seamlessly integrated the U400 into very busy breast cancer clinics around the world, some of the busiest breast cancer clinics in the world. For example, here at Vanderbilt, at Mayo Clinic, at MD Anderson Cancer Center, Columbia University, Macquarie University, just to name a few. And this has been well received, even though the U400 does require us to access premium exam room space for about 5 to 10 minutes to get the bioimpedance measurements, because we do have to lay folks down on the exam table for measurements. I will say, though, we also have to use the exam room for the tape measure, and that takes at least twice to 3 times as long. So the practices have been very happy to see us go in and use the U400 in their settings. The SOZO was not approved when our study began, because we're about 3 years into it. The SOZO has the potential to reduce this time even more and to take away the exam room space requirements. For example, you can have a SOZO machine set up right next to a weigh scale and do both of those measurements seamlessly. Patients have triggered the interventions, and we did an interim analysis with patients who completed their 12-month follow-up in January of this year. And we had 508 patients who completed 12 months of follow-up in the study by then. We had over 100 triggered interventions in those 500. And overall, only 12 participants out of 100 during those first 12 months had progressed following the intervention. And those were broken down by groups as followed. In the tape measure group, 10 of the 12 had progressed, and that was 14.7% of all tape measure patients who triggered the intervention. And in the impedance group, 2 patients had triggered the intervention progression criteria, and that was only 4.9%. This is a very small sample size, but we are encouraged by the findings from the interim analysis. We've also had a recent publication that actually was released online by Lymphatic Research and Biology ahead of press 2 days ago. And this study is a prospective study of LDEX values in breast cancer patients pre-treatment and post-treatment through 12 months post-operatively. And this had over 200 patients in the study. And this is an important publication because in this study, we actually looked at the pre-treatment baseline values of LDEX before anything was done to the women, and compared the values that we found in those pre-treatment sessions to the healthy normal population norms that I showed you back on the slide at the beginning of the presentation. And what we found was very interesting, that the LDEX values in these patients pre-breast cancer treatment were nearly identical to the healthy population norms. Now, this is not true for all lymphedema at-risk populations from people who've been diagnosed with cancer. For example, our head and neck cancer patients in our research have lymphedema well before they have any treatment in many cases. But for breast cancer, that does not appear to be the case, which raises some interesting questions that we're going to try to answer in our next manuscript, which is baseline LDEX really required in order for LDEX assessment to be of value for long-term prospective clinical follow-up of patients after breast cancer treatment? If they start out as normal, then there is a good chance that just any abnormal reading outside normative values would indicate lymphedema and take away perhaps the need for a change score, meaning the difference from baseline to a certain point of LDEX, or even tape measure for that matter, for an intervention to be triggered post surgery. The LDEX standards that we looked at in these patients, coupled with some research published by some other wonderful scientists, led us to establish for this study now an LDEX change of 6.5 from baseline as subclinical lymphedema. And clinical lymphedema, meaning referral out for the lymphedema therapy or lymphedema progression, to be greater than or equal to a 7-unit change for baseline. So these are different because if you recall the slide earlier, clinical LDEX diagnosis prior to this was 10-unit change from baseline. We now know that that is too high. So how are we moving from mysterious to mainstream? Well, first, research has continued incorporating bioimpedance in clinical settings, and the University of Kansas recently published an article where they followed 146 patients using similar inclusion criteria to what we have in our PREVENT trial, and retrospectively looked at their medical records and looked at patients to whom they had prescribed garments early as a potential intervention for slowing down progression of lymphedema. And in that study, 82% of the patients that received those interventions returned to baseline. So that is very encouraging, and that is also an example of a site that's in our current study, University of Kansas Cancer Center, that is also doing clinical use of the U400 in their clinics, but while they simultaneously participate in research to help move the science forward. Patients have continued to demand access to this technology. In the last 15 years, that demand has not stopped, it's gotten greater. And there is now more academic and industry collaboration in making some of these devices and technologies available to the public. And if you look on the other side of the screen, you will see basically in the past 13, 14 years how rapidly the research has moved the field forward. When we started in the early 2000s with lymphometers, you could only use impedance in women to measure arms in breast cancer survivors who had not had anything done to the other arm. In other words, only people who had one arm exposed to cancer or cancer treatment. The XCA moved the field forward by presenting a better platform for data capture, and the U400 moved forward and enabled us to start looking at both female arms and male and female legs, research done with that device. And then continued work with U400 in 2013, enlarged the scope of impedance to include unencumbered, meaning both limbs could be impacted, limbs, unilateral limbs, male and female legs, and female arms. And the SOZO has expanded the field even further, where we can now use FDA-cleared SOZOs for unilateral, bilateral, male and female limbs, arms, and legs. So what you see here is progression of development of technology that has been fed by private research, and now with the PREVENT study, which is a sponsored study from industry and from the federal government, a bigger and larger approach. The target of 1,200 people, and completing this study will be, in my opinion, land-breaking for prevention information for breast cancer patients. So, from mysterious to mainstream clinical applications, we now can use bioimpedance again for the cancer-related lymphedemas, but also in chronic heart failure to look at fat muscle hydration status and intra and extracellular fluid comparators. The clinical guidelines for use of impedance are being revised, and it is a moving target. And as you will see, the American Physical Therapy Association is an early adapter of recommendations for some of these lower LDEX scores being used for diagnosis of breast cancer. And other institutions such as the NLN, the NAPBC, and the Australian Lymphology Association are all endorsing bioimpedance as a legitimate approach to monitoring and diagnosing lymphedema. This is a huge, huge change. So I'd like to have you imagine a new standard of care for all people with arm and leg lymphedema, regardless of the cause, can go to a physician's office, step on a scale, and be measured at every visit. The healthcare professional can see these readings and have better information to assess and immediately manage their patients without having to order expensive diagnostic testing. Imagine a world where patients with arm and leg lymphedema can actually self-measure, like diabetics, their own lymphedema status. And imagine a group of patients, both now male and female, who can powerfully manage their lymphedema and therefore have more control over their life. This is possible now. After 15 years of research using this technology and talking to hundreds of patients around the world, the patient community and healthcare providers are ready to adopt new standards. And it is the obligation of scientists to provide the last bit of evidence required to assist patients and providers in obtaining reimbursement for assessment measures using this technology at home or coverage for coverage for home use and in clinics for assessment. How can this happen? It requires advocacy from organizations such as LE&RN and the NLN to help patients become active and move legislation forward, such as the Lymphedema Treatment Act. It provides activism from patients to absolutely insist that their doctors and healthcare professionals work with them to help approach insurance companies to obtain devices for use at home. And again, the evidence from scientists that this works. We have had a lot of evidence the past 10 years, and there is ample evidence now, I do believe, for this to become a standard of care and for us to look beyond a simple tape measure to more accurate and patient-friendly and work environment, healthcare environment-friendly measurement methods such as impedance. I'd like to stop now and take your questions, and I appreciate all of your attention during this presentation. The first question is, what do patients and healthcare providers need to do to help get insurance coverage for bioimpedance in the home and in the clinic? I think you have to band together to become advocates for yourself with your healthcare providers and talk to your providers about using the technology in their clinic spaces, and also contact your insurance companies and ask verbally and in writing for them to consider covering the use of this technology as research is supportive, that it would be of value to them. You can also work with chapters of organizations such as LE&RN and put together local groups to go to the state legislatures to ask for treatment equality with, for example, diabetics who have such devices available for home use and in clinic use. And put this as an issue where you deserve equal access to health care, and try to get people involved in supporting that message across the U.S. and internationally. The next question is, if breast cancer patients have near normal LDEX values before their surgery, is it really necessary to have a baseline LDEX before surgery? And I think that we are moving towards evidence to suggest that that baseline may not be as critically important as we have thought it was. And the American Physical Therapy Association itself has said that in their guidelines that I showed during the symposium, that anyone with a greater than 7.1 LDEX should be looked at as potentially having lymphedema. So stay tuned. We're doing more research to try to address that as we speak. One question which I get asked often is, do I really think bioimpedance is better than a tape measure? I will answer this first as a scientist. My research has shown that the extracellular fluid that is picked up through LDEX does seem to correlate more with symptom reports than the gross measurement of arm volume. And I will answer that also as a scientist by saying that I've used both types of measurement methods in my study. I have trained research teams on tape measurements now around the globe, and it is very, very difficult to reduce error in measurement for tape. And the slightest misposition of the arm, the slightest repositioning, in other words, if you measure your patient one way, one visit, and a different way the next in terms of arm position, your outcome's not the same. So I just think in terms of accuracy, it's better. And on an anecdotal note, I can also tell you that the patients are much more receptive to the impedance than the tape, which I think was pointed out in one of the questions. It was from someone named Barbara, who said that over half of her time with her therapist was taken up measuring with tapes, and that she would really like to not have that happen. And another person said they had a therapist using the SOZO, and that it was really, quote, neat. So those were some things that came up before we went offline. Another question was, when you did your home monitoring study, how often were the patients asked to measure their arms, and did they do it as directed? They were asked to measure Monday, Wednesdays, and Fridays. We selected those dates based upon the data from the phase 1 protocol development piece of that study. And we had 100% compliance with that, and actually over 100%, because many of them opted to measure more often than what they were asked to do for the protocol. One other comment is, if pretreatment values are elevated, for example, in head and neck, doesn't this suggest that they already have impaired lymphatic function from cancer? So they have perioperative lymphedema. Yes, it does suggest that we truly believe that in head and neck, the tumor's size and or their inflammatory processes cause lymphatic damage and result in pretreatment lymphedema. We will soon have an article out in Lymphatic Research in Biology that discusses these inflammatory biomarkers and cytokines that we have followed pre-treatment and up to 18 months post in head and neck cancer patients. And I think that will provide some insight as to some of the mechanisms for this pre-treatment development of lymphedema. Another person asks, so much information is about, and for those with cancer, and many of us don't have that. And I guess I can say to you that I agree with you that many of you don't have cancer-related lymphedema. And we have done other studies in non-cancer populations which are published, and we are continuing to look at options for non-cancer populations in our research here at Vanderbilt. The impedance technology that we discussed today in the seminar, however, doesn't care one way or the other literally, if your swelling is from primary lymphedema or from cancer, it can measure a limb and give you readings regardless of the cause. So the information that we've gotten from breast cancer patients who are very ready and willing and eager to be in research studies translates pretty well to people who have different types of lymphedema, as long as it's located in their arms and legs. And I think that's part of the question, what patient populations other than cancer could bioimpedance help? And it could be used with primary lymphedema. It could be used in patients who have had trauma in their legs and automobile accidents or other unfortunate series of traumas to measure the limbs regardless of cause. Beyond the lymphatic community, there's research now being done extensively in heart failure using this technology because, again, it's non-invasive, quick, and accurate. We have another comment that says, I would like to see a graph of limb lymphedema, severity, and LDEX scores. And we will be working on that in our publications. So you will be able to see that in the near future. And I could just say, hang on. We are very excited about some of the research that we're doing here. One question that's come in is, the cost of a glucose meter is such that diabetics can afford a unit for home use. Is the SOZO unit or its home version going to be manufactured at a low enough price point? I don't work for the company, but I would assume if they want a home market, they will have to be looking at price points for that device. The glucometers, when they first came out, were actually more expensive than they are now. I've been a nurse for more decades than I care to think about, and as demand increased, the cost went down, and hopefully that would be what we would see with this. The next question is, how will you select the final patients for the study? They will come from the sites that are enrolled in the study worldwide, and they will be selected based on the same inclusion criteria. The first 1,100 have been selected. And if you're asking, are we looking for community volunteers? The PREVENT study really requires you to be newly diagnosed with breast cancer and getting care in a clinic. So we can't take community volunteers for those last 4 slots. If any of you are interested in participating in research, you're welcome to contact me at sheila.ridner@vanderbilt.edu, and I'll be happy to see what I can do to help you get more involved. Okay, well, I think that's all the questions. I appreciate your attention during the symposium and the questions at the end. Thanks to LE&RN for hosting the seminar, and I look forward to hearing from all of you if you have any questions. Thank you.